Hello everyone. We are going to wait a minute maybe for people to join and then we will start with the webinar. Okay, I guess we can start already. So welcome everyone to today's webinar, Novel Monitoring Tools to Detect Chronic Over or Under Treatment in Children with CAH. My name is Camelia Markowska and I will be hosting today's webinar. I first want to say thank you to MTG1 for organizing this webinar and making it happen. Svetlana is our chair today and she will present the speakers just in a moment. I just want to say that all questions are going to come after each presentations. You can write your questions in the question box, which you will find in the upper right corner. So without further ado, I will give the word to Svetlana to present our speakers today.
So good afternoon, everybody. I'm Svetlana Leitch from the Karolinska University Hospital, and I would like to present for speakers today for this webinar on CAH. And the first speaker will be Erika van den Akker and Sjoerd van der Berg from Sophia Children's Hospital in Rotterdam, who will be talking about congenital adrenal hyperplasia, current guidelines and monitoring. And after each speaker, we have also questions for each speaker. So we don't have the questions in the end, but after each talk. And the second speaker will be leukocyte telomere length in children with congenital adrenal hyperplasia, presented by Dr. Ozair Abawi, also from Sophia Children's Hospital in Rotterdam. And the third speaker, we have Professor Christa Flueck from Bern, presenting predicting treatment outcome in CAH using urine, steroidomics, and artificial intelligence. And the fourth speaker, Dr. Claudia Boettcher, also from Bern, who will be talking about the effect of oral contraceptives in female adolescents with 21-hydroxylase deficiency, a prospective observational study. So welcome, and let us start with Erika and Sjoerd.
Thank you so much, Svetlana, for this invitation, and welcome everybody. We will have this webinar on congenital adrenal hyperplasia, and which is quite a prevalent genetic disorder in endocrinology. And in this webinar, we will explore novel insights, best practices, and research that can improve patient outcome. So let's dive deeper. My name is Erika van den Akker. I'm a professor in pediatric endocrinology at Erasmus MC, the Netherlands, and I will do the first part together with Sjoerd van der Berg from clinical chemistry. And this is our group in Rotterdam, the Netherlands. You may know some of them. My colleagues are specialized among disorders of growth, sex development. Judith van Eck is nurse specialist on adrenal and transitional care, and Gert de Kerkhoff on Prader-Willi syndrome. But for the group, it's very important to rely on good clinical chemistry, on good diagnostic lab endocrinology. And therefore, I also put in the picture of Sjoerd van der Berg, because he's important in the innovation of those assays. You will hear more about that a bit later. And of course, we have quite a large population of patients, and we also contribute to the registry of Endo-ERN, the Eureka, with among all themes actually, but for today, of course, it's good to know also that you can register patients with congenital adrenal hyperplasia, and we already published on that and have much larger numbers through working together internationally in this registry. But let's switch to congenital adrenal hyperplasia. It is a condition that stems from either a partial or a total deficiency from an enzyme in the adrenal gland. Usually it's most prevalent, in most cases, it's 21-hydroxylase enzyme, which is deficient in the adrenal cortex. And this disruption leads to a variable degree of cortisol deficiency, aldosterone deficiency, and subsequently to ACTH pressure, leading to an excessive androgen production. And this gives the clinical presentation partly of adrenal insufficiency or due to the hyperandrogenism to disorders of sex development in girls, to short stature in adulthood due to advanced bone age, or to hirsutism. And as specialists in endocrinology, our role is to optimize the management of CAH in a way to minimize the risks. And this means good monitoring and good dosing of the medication. Because we know that that is really hard. Because patients are known to have long-term risks on health. And these risks come from either over treatment or under treatment. For example, there's increased risk of obesity, hypertension, osteoporosis, and reduced quality of life and fertility. And the poor health status of adults with CAH seems to be a result of their treatment. Therefore, patient care needs to be improved and hormone replacement therapy needs to be optimized. So, increasing doses of glucocorticoids as a replacement for cortisol does not necessarily result in improved disease control because it can have adverse health consequences in long term. So the main goal is to monitor what can we do to monitor that treatment well. So in childhood we monitor especially on weight and height development, on the pubertal assessment, on lab assessment, and on bone age. And this is what the current guideline says on that monitoring. We monitor on, especially in the guideline, it says especially on serum levels of 17-hydroxyprogesterone, trying to indicate a little bit above the upper limit, because if you aim at the normal reference range, you usually overtreat. For androstenedione, you aim at the reference range, and ACTH is generally not used as a monitoring tool. But there are new ways to monitor. There are also new matrices like saliva, urine, hair that could be used for monitoring. And because it needs to be, and there are lots of groups working on it, of course. Today we have presenters from different centers, and here you see the 3 centers which collaborated in the past years. It started on an SP research unit fund, and it still continues to collaborate between Rotterdam, Bern, and Athens. And outcomes of those projects will be shown today. And first, let's talk about other possibilities to measure and monitor CAH hormones. Sjoerd, can you take over here?
Yes, definitely. So I've prepared a part of the presentation on the role of the clinical laboratory in the area of the guidelines which are currently in place for CAH. I don't know for sure if I can skip the slides myself. Probably Erika has to do that. Um, and if we put it in perspective, we as a clinical laboratory, we try to make our test fit for purpose as much as possible. So it all starts with guidelines. We go on websites, we see what people come up with for us to do, and in terms of CAH, we go to the SP website, we look at the consensus statement and guidelines, and there is a small animation there. Can you click, Erica? Yeah. So there are two documents on that website. There's a guideline from 2002, which is quite a while ago, but there is a little more recent guideline from the Endocrine Society from 2018. And the part of the presentation which I am doing now is on the 2018 guideline, the endorsed guideline. Yeah, next slide, please. So if you take that part in that guideline, which is representative for the laboratory, we can look at what we have to do, so what to measure. We can look at from where to measure, so in what sample matrix. And in some, but not all guidelines, it also says how to measure that. And if we go into this guideline, it says we have to measure 17-hydroxyprogesterone, which is probably known to all of you as the metabolite which accumulates due to the enzyme deficiency. Androstenedione and testosterone as the hallmarks of the phenotype. We can do that in blood and in saliva, and there is some evidence you can also look at urine that will be presented later as well. And we can do that on either dried filter paper or whole blood. And this guideline is very specific. It says you have to measure that using extraction chromatography or extraction immunoassay as the method of choice. And I think speaking from a laboratory perspective, there is next to none laboratory who is not using LC-mass spectrometry now at this moment in time. Okay, next slide, please. So for the just as an overview, this is a paper published in the Endocrine Reviews from the Nijmegen group, showing the steroids which either accumulate in 21-hydroxylase or is surrounding the accumulating steroids. There is an animation there. If you click, you can see the 17-hydroxyprogesterone as the direct precursor to cortisol. And the androstenedione and testosterone as a form of an escape of the block. Yes, next click, please. And what you probably all have heard of in the past, but which is not in the guideline, and there will be a large part of this presentation, is about 21-deoxycortisol as a more specific marker of the enzyme deficiency, and the 11-hydroxyandrostenedione and 11-ketotestosterone as the probably most likely novel markers for therapy control. Next slide, please. So there's a whole body of literature coming out now, not just on CAH, but also on phenotypes which are related to that, like PCOS, on 11 oxygenated androgens. This is just one of them. This is a very recent paper from one of the biggest authors in this field, so I can say, Richard Akker, on the measurement and the validity of measurement and the additional value of 11-hydroxyandrostenedione and 11-ketotestosterone in the phenotype and the monitoring of CAH. And next slide, please. And the reason for that, why are these two metabolites so interesting? Just if you can click further, then are these so interesting? Yeah, next slide is fine. So why are these so interesting is that 11-hydroxyandrostenedione is a steroid which is exclusively produced by the adrenal. And not just exclusively, it is exclusively produced in very high amounts. Apart from DHEA, this is the steroid which is produced by the adrenal in the most predominant way. So the highest concentration per time unit, apart from DHEA. So elevated levels or elevated flux of 11-hydroxyandrostenedione gives you a very good indication that the adrenal is producing a lot of steroids, and probably it will also tell you something that the adrenal is producing too much. So the exact way to interpret this data in CAH is not yet known at this exact moment in time, but we are looking into that, and there's becoming more and more evidence that it is most likely more a better marker compared to 17-hydroxyprogesterone, just to look at steroid production. If you can go to the next slide, why are we looking in 11-keto-testosterone? And that is not just this androgen is not produced solely by the adrenal, but it is produced by the adrenal in very high amounts in patients with CAH. There's quite some literature, quite some recent literature on steroid profiles, including these androgens in patients which are controlled by cortisol, which are not controlled by cortisol, and in let's say wild type phenotypes. And if I say a matter of numbers, on the next slide you will see that it is truly a matter of numbers, because we all know that androgens and cortisol precursors accumulate in CAH, but they do not accumulate into the same amount. So if you click one step further, you can see the difference between the amount of androgens produced in well-controlled, cortisol-controlled CAH patients with 21-hydroxylase deficiency. On the y-axis, you can also already see the enormous difference in the total amount of androgen in the blood. And I think there's a small animation there that looking at testosterone levels, the median 11-keto testosterone concentration is way higher compared to total testosterone concentration. So it's truly a matter of numbers. If you can go to the next slide. So what we will do as a laboratory, we will not stop measuring testosterone and androstenedione, but we will probably add 11-hydroxyandrostenedione and 11-keto-testosterone. So and talking for the Netherlands, we're not the biggest of the country, but we are already 2 or 3 laboratories who can provide you with these numbers 2 or 3 times a week. And then going to from where to measure. So in the guideline, it says you can measure blood and saliva and urine. And on the next slide, I will give you some data on that. So why can we not? Why are we looking into different matrices than blood? Because we prefer not to measure in blood, because these patients, they are at home, we know what they have, we know how they are treated. We try and make them as comfortable as possible. So giving sampling at home is the method of choice. So looking into salivary concentrations of the 17-hydroxyprogesterone, comparing that to blood, and this is already very old data, 15 years ago. This was published by the Rotterdam group, that there's a very strong correlation between the two, and that the salivary measurement is a very good proxy for what is happening in the blood. And then the next slide, you can see, next slide, please. So in the next slide, there's a paper from the Nijmegen group looking into patients who are being treated for 21-hydroxylase deficiency. You can see that there is a temporal change in the concentration of these steroids, even when patients are well controlled. You can also see that it's easier for us as a laboratory to measure androstenedione compared to 17-hydroxyprogesterone, because 17-hydroxyprogesterone in the saliva, the concentrations are so low that even using the most sensitive equipment which is available at this time, it is very hard to make an educated guess on the exact concentration. And if you click 2 times further, it is still a snapshot. So you can do the salivary concentration. You can ask a patient to collect salivary steroids once a day, maybe 2 times a day, but not every day, and not every day of the week 6 times a day. Whereas that if you look into recent literature, it is still advocated that you need regular monitoring preferably several times a day. So that is a very hard combination to make. Also for us as laboratories, because it takes quite some time to measure a sample. And the next slide. Yeah. So, so that it is an option. Definitely, it is an option, and we can do that. And we can not only measure 17-hydroxyprogesterone and androstenedione, but in our multiplex LC-MS assays, we can also use and measure the more novel steroids. So the steroids I already hinted on, the 11-hydroxyandrostenedione, 11-ketotestosterone. These are measurable in saliva. Day-to-day profiles are known, even in patients which are being treated. So you can go for that. But then again, like I said, it is still a snapshot of the patient at that exact moment in time, because these numbers can fluctuate over a day. Next slide, please. So going back to the drawing board and looking from a laboratory perspective, so we tried to devise the ideal test for this patient group because they are at home. We know what they have. We know how they're treated. So preferably we sample at home. Given the fact that we tend not to hurt the patient, we would prefer a test which is measured in a non-invasive way, so a matrix which is easily accessible. It should be relatively cheap because our hospital administration would like that. It should be specific for 21-hydroxylase or different types of CAH in that perspective, and it will preferably give us more information than just a snapshot. And if you click one time, this is one of the pet peeves of this hospital. We've been doing a lot of work on that. We love to measure things in hair because that gives us an overview of a longer period of time. And if you can go to the next slide, we set up an assay in the last few years measuring exactly that. So there are some stars in this overview. We have set up an assay measuring in hair, not just cortisol, because we have a lot of experience in that, but we also have devised an assay to measure steroids in hair, 17-hydroxyprogesterone, the classic androgens, androstenedione, and testosterone, and the more novel, more advocated steroids at this moment. We can also measure in hair 11-hydroxyandrostenedione and the 11-ketotestosterone. And in the next slide, not even Erica has seen these data because we have just measured them over the last few weeks. This is unpublished data of patients, 3 or 4 patients, CAH, cortisol treated, well controlled, if I understand the patient file correctly. And there you can see that 11-ketotestosterone is measurable in hair. It is different between patients by definition. So in males, it's higher compared to females. You can also see there is some fluctuation, which we do not see in normal subjects, in non-CAH subjects. So we tend to think that the fluctuation in these concentrations gives us some information on the treatment efficacy, and it's the same is true for 11-hydroxyandrostenedione on the right-hand side of this graph. If you go to the next slide. Yeah, so that's where we are now. So we know what to measure. We'll preferably give you more information, just testosterone and androstenedione. We would like to give you that information not from the blood, but also in saliva, and hopefully in the near to next future in hair. And the how to measure is on the next slide. We can be short about that. We're not going to move away from the previous guideline. We're going to stick with mass spectrometry because it's just unfeasible to do that by immunoassay. We are also advocating on how to interpret these data. So please, if you have access to hair, if you have access to continuous data, use them as such. Don't use them on a one-to-one basis as you did to blood or saliva. There is a very strong correlation on steroids in segmented hair. So the first centimeter of hair has a certain concentration, which can predict the second and the third centimeter of hair. We tend to think of it as a continuum, as a reflection of the patient health status. It already works for cortisol and cortisone, So if you look at normal subjects, you can predict cortisol and concentrations in hair from 1 centimeter to the other, and probably this will also work with the other steroids which I've just presented. To the next slide, please. And you can see that from this, and here you see the 4 patients which are controlled for CAH. Compared to the previous slide, you see, as I said, more fluctuation in the cortisol concentration, which is not unsurprising in patients who cannot make their own cortisol concentration. And we try, and we will see in the near future if any fluctuations would also translate to therapy intervention. So as a wrap up, what to measure? So we will not stop measuring the classic androgens. We will not stop measuring 17-hydroxyprogesterone, but we will add the 11 oxygenated steroids. We will provide you with blood, saliva, and hopefully hair in the next future, and we will continue to use mass spectrometry and try to interpret the data as a continuum to have that glimpse of the patient health status over a longer period of time when being treated. And that is it.
I think there's now some time for questions, but right?
Yes, let us see if we have any questions. Trying to identify this chat box.
There are no questions yet. That's
No
fine.
questions so far, as I can see.
We can proceed.
Okay, we have time afterwards as well for questions. If somebody would like to present it in the chat or in the questions box. So now we have the third speaker, which is Dr. Ozair Abawi, also from Rotterdam. Welcome, Ozair.
Thank you for introduction. I will share my screen. So thank you for the introduction. My name is Ozair Abawi, and I will present part of our findings of the study that Professor van Akker referred to on novel treatment monitoring tools. And this was a collaboration, as said, between the Children's Hospitals of Bern, Rotterdam, and Athens in Greece. And in this specific presentation, I will show you the results of our analysis on leukocyte telomere length in children with CAH. This study has also been published in recent years in the JCEM, so if you are interested for further reading, I can refer you to the publication. So as Professor van Akker already mentioned, treatment of patients with CAH is quite difficult. In the current state of care, patients have regular visits to their pediatric endocrinologist, usually between 3 to 6 months apart, depending on the age category the patient lies in, and they receive a hydrocortisone or hydrocortisone equivalent glucocorticoid substitution dose. We hope to keep them in the 8 to 12 milligrams per square meters per day range, and sometimes some patients need more, and especially they need more in case of illness and stress. And as Professor van Akker also alluded to already, there is a broad clinical evaluation which we do to try to investigate whether the treatment is well balanced. Height and weight, blood pressure, pubertal staging, and also classic androgens such as 17-hydroxyprogesterone and androstenedione, and also for the longer term, the bone age and the gonadal ultrasound. So finding that balance between overtreatment and undertreatment, so hypercortisolism on one hand and hyperandrogenism on the other hand, is proven to be difficult in patients with CAH, especially in growing children. And both have their negative effects. So if the treatment shifts towards the overtreatment, so the hypercortisolism, There are many known long-term effects on growth, so retardation, weight gain, osteoporosis, and negative influences on glucose tolerance and psychological well-being. But on the other hand, undertreating patients also has effects on growth, which first can accelerate but results in reduced final height, can lead to weight changes, abnormal puberty and fertility, especially in women, hirsutism and amenorrhea. Also, of course, negative psychological well-being has well been documented, and risk of adrenal crisis. So finding that balance is really important. And the overarching aim of this study was to develop novel treatment monitoring tools to detect this chronic over and under treatment in these treated children. And I will focus on the part on the leukocyte telomere length, and Professor Flueck will tell you a bit more about the urine steroid analysis that we have performed. So what are leukocytes, or what is the leukocyte telomere length? Well, as you all know, we consider leukocytes to be the caps of chromosomes, where in fact they are tandem repeats of a non-coding sequence at the end of each mammalian chromosome, and their main function is to protect cells against degradation during cell divisions. But we also know that LTL shortening is, as you can guess, associated with normal aging, but also a biomarker for disease states with accelerated biological aging, but also cardiovascular diseases and obesity, and chronic stress and hypercortisolism. What was surprising also to me before we performed this study is that the leukocyte telomere length is a dynamic marker. So it means that it can also increase again when you remove the, for example, chronic stress, or when you return from a state of chronic hypercortisolism to normal cortisolism. So it should be regarded as a dynamic marker, and thus treatments can influence it. So for this analysis, our main research question was whether leukocyte telomere length can also be associated with treatment quality in children and adolescents with CAH, and therefore if it possibly in the future could be of any use in conjunction, for example, with other monitoring tools to monitor the glucocorticoid treatment in these patients. So for this overarching study, we included patients with a genetically confirmed CAH due to 21-hydroxylase deficiency that were either pubertal in tenor stage 1 or late pubertal, so post-menarche or tenor stage 3 or higher. And we excluded children who had intercurrent illnesses before the study visits. And in total, we included for this specific analysis on the leukocyte telomere length 75 patients on glucocorticoid treatment from the 3 countries that were mentioned before. So a short overview of the study. The study started with a baseline visit or a run-in period where we collected clinical data based on the current standard of care, and then 2 study visits where, apart from the routine measurements, we also collected the study measurements, DNA, serum, urine, and hair. And for this analysis, I will focus on the DNA analysis. So what we did measure, we did a routine measurement of 17-hydroxyprogesterone and androstenedione at both study visits, and then also at both study visits, we measured leukocyte telomere length using a state-of-the-art technology, the multiplex qualitative real-time PCR. For the analysis, we performed linear mixed model studies, which we adjusted for age, sex, and BMI Z-score, and we investigated associations of the leukocyte telomere length with treatment quality, which was our primary research question, and then as secondary research questions, also we investigated subgroups of patients, so patients with classic versus non-classic CAH, patients stratified of the type of glucocorticoid treatment, so hydrocortisone versus prednisolone, and the daily glucocorticoid dose that these patients received. So here you see the flowchart of the study, and here it says 76 patients, but 1 patient did not receive glucocorticoid treatment during the study, so we did not include that patient in subsequent analyses. Here you see an overview of the patients that were included, stratified on type of CAH. As you can see, there were slightly less females than males. The average age was around 12 years old, and there were slightly more pubertal children than prepubertal children in both groups. Here in this table, you can see the treatment characteristics of the patients, again stratified on the type of CAH. And if you look in the left column, most children received only hydrocortisone, And then some patients, so a small subgroup, received prednisolone treatment or prednisolone in conjunction with hydrocortisone. And the daily hydrocortisone equivalent dose was around 12 micrograms per square meters. And then you see the treatment quality as assessed by the pediatric endocrinologist. And we categorized 3 groups of patients: undertreated, optimally treated, or overtreated. And this was based on the full clinical examination during a study visit. So the pediatric endocrinologist incorporated all available data, biochemical, but also height, weight, puberty, etc. So all the points that we mentioned previously. So when we use this as a proxy for the treatment quality status, we saw that most children, thankfully, were optimally treated, as you see, around 60% in the total cohort, where a larger subgroup was undertreated and a smaller subgroup was overtreated. This is the data for the first study visit. I will not show the data for the second study visit, but it was similar to the first study visit. So then we also wondered, so what was the rationale for adapting the glucocorticoid dose for the pediatric endocrinologists for the patients that were either undertreated or overtreated? And here you see an overview. The numbers count up to more than 100% because there can be, of course, several rationales to adapt the glucocorticoid dose. And you see that in the majority of patients, the lab results were the reason to adapt the glucocorticoid dose. So in case of undertreatment, to increase the dose, or in case of overtreatment, to reduce the dose. And other rationales that were often mentioned were being on an already very high dose, weight changes, or growth changes. So what did we find in terms of the leukocyte telomere length? Well, on a group level, we found a median LTL of around 1.2 at the first and second study visit. We did not include a control group of healthy children by design in the study, but based on previous studies that were performed in Greece using the same method, we know that this is quite similar to children of the average age of the study population. When we performed in our patients with CAH univariate analysis, we saw, indeed, as we expected, a negative association of leukocyte telomere length with age, but not with sex or with BMI Z-score. Here you see the main study findings, namely the results of the linear mixed models on the leukocyte telomere length. So as you can see, age has a slight negative association indicated by the asterisk as being statistically significant. So you see on the x-axis the beta coefficients of the linear mixed models. To the left is negative coefficients, and to the right positive coefficients, and then you see the different sub-analyses that we performed. So as you can see, age is slightly negatively associated with leukocyte telomere length, whereas sex wasn't, and BMI Z-score also wasn't, and puberty status also wasn't. But we saw a clear difference between patients with non-classic and classic CAH. So the patients with classic CAH had quite lower leukocyte telomere length. The same was the case for the patients being treated on prednisolone versus hydrocortisone, and I will get back to these two results in more detail in a bit. The absolute hydrocortisone equivalent dose was not associated with the leukocyte telomere length, neither was the duration of the treatment. And then when we looked at treatment quality, we saw an interesting effect where compared to children with optimal treatment, patients that were undertreated did not have a differing leukocyte telomere length, implying that an increased androgen burden per se does not influence the leukocyte telomere length, but overtreated patients did show a negative association with leukocyte telomere length, so implying that indeed the hypercortisolism in these patients was associated with a reduction in their leukocyte telomere length. So what we can conclude from these analyses is that the leukocyte telomere length is shorter in patients with classic versus non-classic CAH, and in overtreated versus optimally treated patients, and in patients that are treated with long-acting glucocorticoids versus hydrocortisone. And all of these three analyses point towards the direction that chronic exposure to supraphysiologic physiological glucocorticoid concentrations can negatively impact LTL in patients with CAH. Therefore, the results of this preliminary analysis imply that LTL in the future might have merit in monitoring glucocorticoid treatment. Of course, you would want to have longer follow-up duration and associate it with the adverse sequelae of over and under treatment, and especially over treatment. But I think this was a very interesting base for the for future studies, showing that this indeed might have merit. So I want to thank you for the attention, and I give the word back to the chair.
Thank you very much, Ozair. So I think we have a few questions here in the chat. I think the first one was for the first speakers. Are there now gender and age-specific norms for 11-hydroxyandrogens in the matrices like saliva and hair?
Yeah, I think the question can be answered with yes. So there are data published on reference intervals in children and adults. They are all on PubMed. There's also a paper on the salivary profile of 11 oxygenated androgens in patients with CAH. It's also on PubMed. The data on children, it is scarce. So on adults, there's quite some data. In children, it's scarce. In hair, no, there are no reference intervals, good reference intervals for oxygenated androgens in hair published yet. We are collecting the data as we speak now, also in patients with CAH.
Okay. I think that was all the questions for now. I just look in the other box as well. No other questions. So we say welcome to Professor Christa Flueck, who will talk about predicting treatment outcome using the urine steroidomics and artificial intelligence.
Hello. Just to check, do you see my slides?
Yes.
Okay.
All fine.
Thank you very much for inviting us also to present our data of this very nice collaborative work between the three centers. And as Svetlana says, I'm now moving to the part where we investigated the urine. Now the slides don't move, huh? Okay, these are my disclosures. Now, the objectives of this presentation is that I quickly give a certain background on steroidogenesis and systems biology to make you understand that what is synthesized in the adrenal will be converted in the system, and how it ends up in the urine, which can be another kind of biomaterial where you can apply steroid biochemistry, as we just heard, for blood or saliva. And then I will concentrate on another study where Ozair also invested a lot of time with me to analyze these 24-hour urines, right? So I think it's very important to realize when we talk about CAH, it's a disorder in the adrenal, highly specific of an enzyme, CYP21 hydroxylase. But whatever we measure afterwards, be it on a hair or be it in the blood or in the urine, sees a lot of further conversion in the periphery and will mix with other steroids originating for other organs, which are displayed on this slide. So we have the gonads, which interplay a lot. If we measure in a mother, it's the mother fetal placental unit, and we don't even know a lot about the brain steroids. Maybe they don't interfere too much, but there are neurosteroids which are highly interesting, but there is a lot to be done to understand them. As I said, once these steroids are synthesized in the specific organs, as we talk in the adrenal cortex, and they are secreted from there partially, then they reach the periphery. And the liver and for instance also the fatty tissue or the hair, there are machineries which take precursors and they turn them over and again put them back into matrices like the serum or a hair or so on. Also, then we have to realize we have a big opportunity because 99% of all these steroids, they are excreted through the urine. Another advantage is that if you collect 24-hour urine, you can integrate these steroids which have been secreted, and I will come back to this in a moment. So I just quickly show you again this machinery. Don't forget the gonad doesn't have 21, but can take steroids and convert them and can contribute especially to this androgen pool. And will screw up whatever you think about comes only from the adrenal if you don't understand the complex machinery which contributes, as I said, to systems biology. So you have here contributors from similar steroids, same classes, which you might then at the end of the day find in the urine, which contribute. But of course, if you have 21 hydroxylase deficiency, and the machinery of the adrenal cortex, which is depicted here with all the backdoor and the 11 oxys, then these go to the same pool, and you have to understand how to interpret the data which you get after all these nice analytical methods. And here is the machinery again in a nice review from Turco and Okos, what the periphery contributes, and that you can take these steroids and take them also to a next step, not even in these organs which are called the primary steroid producing organs. So this is basics you need to understand when you then look at the very complex material like urine. So how do we measure? It's a little bit more difficult than in the kitchen. And there is a lot of pre-analytical issues that you have. The material matters, we have heard that we can measure from many things. You have to understand when it's taken, this snapshot that you take, if you take a sample of a saliva or a blood versus if you take a 24-hour collection versus a spot urine, or as we just heard, the big opportunity if you take a hair, where you can say 1 centimeter of hair next to your scalp will maybe be the last month, right? Another thing is you have to understand is age of your patient, sex of your patient, the pubertal development they are in, like we just had this question, do we have normative value, is something very important. Another thing is stimulation medications and outside effects. Those are all things which you need to consider, which play an important role in pre-analytics. But now let's concentrate on the urine. Steroid measurements by mass spectrometry is now the method of choice if it comes to steroid measurements, because immunoassays, you can see that on the left-hand side, they just provide one steroid at a time per measurement, although they are rapid, cheap, and widely available, but they depend largely on antibody sensitivity and specificity, and antibodies are not available for most of these intermediate metabolites that we are now interested in. Whereas if you go to steroid profiling, you get lots of steroid at a time. It depends how these methods are then kind of standardized, but you can get out of one measurement many steroids. It's less rapid, more laborsome. You need experts in the field. It's more expensive and more exclusive, one can say, but much more comprehensive. And gold standard because of its high specificity and sensitivity. Here is a picture of a GCMS. LCMS is similar. You have on one side, before the mass spectrometry, a gas chromatography versus a liquid chromatography. Here in Bern, we have all the machinery since 40 years with lots of experience. Currently, In our routine, we measure 17 steroids in the routine mode out of plasma and 40 steroids out of urine in routine. In the research mode, we are higher up, doubling both numbers with novel steroids, which we can measure. But standardization and validation is a big issue because most labs have in-house methods, and that's something which we have to solve into the future. So here is just how it goes when you take a urine. You see on the right-hand side to get a little bit of taste. You have to extract the steroids first with multi-steps and put them afterwards on the mass spectrometry. So to work up samples in our routine mode, we can do 20, max 40 samples a week. It takes 2 days. For full sample prep and then measurement, and then of course much less time from data analysis and reporting, but it's quite a laborious and also costly method. Here are the two girls who are the leaders in the urine steroid metabolomics, and on the platform we are certified meantime, and for all these methods, of course not for all methods in the research mode. In the serum versus urine steroid world, you have to then get acquainted with more metabolites than we usually are. You see here mineralocorticoids, we all know aldosterone, but not capitalized and italicized. You see metabolites, which I don't name any of them now because it's too complicated, but just to tell you that from all these intermediates going to either aldosterone, cortisol, or the androgens, through the peripheral metabolism before they come in the urine, you get 3 to 5 to 6 metabolites, which you have to recognize from where they come. And that's very important when it comes to interpretation of urine steroidomics. Therefore, any urine which is sent to us will not go out without an expert interpretation, because you cannot just send these to clinicians and expect them to be able to read such a urine steroid profile. So, and there we are. To make it more simple, you see now such a glass chromatographic mass spectrometric profile of a urine, and then you need to be able to recognize pattern. And what we do now, we move that we have, when we have enough to feed machine learning, that basically you can replace then over time the experienced doctors or specialists by machine learning to interpret in this profiling. And with that, we come to part 2 in our study, collaborative, when we collected from these 3 centers. And we said, okay, let's look at whether urine might be an opportunity to do metabolic control in CAH. As previously said, CAH is like walking in the Swiss mountains on a crest. You can fall down on both sides, either in under-treatment or over-treatment, and we really want to avoid that, right? This scheme you have also seen. I just draw to the right-hand side that basically in CAH you are opening novel pathways, and which kind of give you a different pattern to classic 11-oxy or backdoor pathway steroids. And that gives then the pattern to actually think about it, whether we can really interpret metabolic control in CAH. CAH to recognize in a urine as a diagnostic tool is very easy if you know where to look. But the problem is that if you have a patient which is good controlled or not so good controlled, if the differences get minor, it becomes more difficult. So what we did, also I just explained a minute ago, we had from the C centers all this biomaterial, and now in this study we asked the question, can we predict metabolic control by urine markers assessed in a 24-hour urine sample? And it's just actually accepted for publication yesterday. So again, we have these patients. For the urine, overall, we were able to include 59 patients, and they were non-classic and classic. We included for that only 21 hydroxylase deficiency. We had very few which had 3 beta or 11 hydroxylase, and that's of course giving a different pattern. And Erika also explained nicely at the beginning how in routine we are actually judging good or optimal control versus under treatment and over treatment, because in all 3 centers, the doctors, the more experienced doctors, were actually saying, is this patient in a good phase or not such a good phase, because we needed to compare to something when we come with our results of the urine steroid profiling. So we did that, and here you see the scheme, which is, as I said, just published, is online, how we were actually saying that a patient would go into this or another group. And because we then were too good in our 3 centers, I have to say, we had only 1 patient and then 2 in the second visit who actually qualified by expert opinion for overtreatment, because that's very easy to see, because then they are completely suppressed. So we all try to avoid that. So in this study, we were only able to say whether they are in good metabolic control or undertreated. And we measured then, as I just explained, in a 24-hour urine collection, the different metabolites, and you can see we came up with significantly differences between optimal treatment and under treatment, with 2 representatives which were highly significant, the 17-hydroxy-P and the 5-PT, and I just show them to you in this nice scheme. So you see, it makes a lot of sense. These metabolites, where do we find them when you are undertreated? They are to be found before the 21-hydroxylase block. Here, metabolites. Because of ACTH stimulation, you can find some of them here in the way to aldosterone. And then you can find them, of course, on their way to androgens. And you find them on the way to 11-oxyandrogens, but also to the other androgen, the classic ones and the backdoor ones. So basically we have a picture which then gives a pattern which makes a lot of sense. And if you know these metabolites, which actually also gives you the diagnosis of 21-hydroxylase deficiency. But as I said, it's a matter of effect size, whether you can discriminate good control versus less good control. And therefore, to say that, you need maybe a more subtle differences to recognize. And when you do then further analysis, which also I did with some experts from statistics, you can also clearly show that, of course, lots of these metabolites which you will measure in a urine, they are highly correlated. And they come from all classes. The androgens are correlated, the precursor progesterones, the estrogen, sex hormones with the androgens, and of course also the cortisons. And you can get to this nice picture to kind of also have a quality control of your data analysis. Then if you go into principal component analysis and you ask the question, how is treatment quality affecting? You see here the plot for optimal treated and under treatment. When you just take the lab results, you can see the plots for if you are looking classic, non-classic CAH, highly overlapping. And then if you take 5 principal components and how they contribute as the chemicals, metabolites which you find in urine, some of them are much more prominent than others. And if you go and ask the question whether hydrocortisone versus prednisone treatment, you see this is really a nice plot which shows this discriminates highly. and you have a sex difference between females and males, which is not that high, because we had, then you see under D, we had children before puberty or pubertal in our study, and they discriminate also. So we had to control for all of that, when actually at the end of the day, we wanted to find the principal components, and we wanted to also have not too many. Lucky enough, or good enough, all three centers, as I said, we were too good to have overtreatment, and we also, all of us, since we highly standardized how we actually judge the patients up front, it was a prospective study, so it didn't really matter in which study site they were, Athens, Bern, or Rotterdam. And then if we then come to what is actually then important in a lab, do we find discriminating markers for saying whether something is a good marker for good control or not so good control? Here you can see that yes, we can do that, and we found really with very good, or at least good, area under the curve to discriminate of 0.87, which is good. Components which qualify for undertreatment, these two steroids, which are quite nicely known also in the diagnostics of 21-hydroxylase deficiency from urine, versus which components actually qualify optimal treatment. So we find contributors type 1 and type 2, and there are not too many now, if you now think of 40 components out of the urine, which also offers the opportunity that maybe in the future, to just solve the question whether a CAH would be good controlled, we could concentrate maybe on these components. The next question is then, if you look at this as a pediatric endocrinologist, is the question, do we need the doctor anymore? Because if we can send a 24-hour urine of a CAH patient to a specialized lab, and they can take this and then validate it and say, your patient is in good control with such a nice discrimination, then maybe we don't need the doctor anymore. So what we did, we did the reanalysis Ozair, and we've asked the question, if you put in the clinical components, which then are much more, you see here, we reach a little bit a better ROC discrimination of 0.9, but really not too much more. But lucky enough, we realized also that in some, it really didn't work. And those were the non-compliant patients, because that really no machine learning and no lab can actually diagnose, right? Whether your patient is just saying something or whether it's real. So we had some discrimination. And finally, in addition, because Ozair worked hard with the statistician to come with the principal component analysis and these complex statistics, we were asking the question, if we just now take the data and we deliver it to machine learning, which of course is underlying lots of this same knowledge in the basis, and we take 6 models which are used in machine learning, and ask the question, can we find a model which can be applied in the future in our lab, like we have also for PCOS nowadays? And then instead of having somebody sitting for hours and making all this analysis, that we can just take the algorithm after the results come from the machine and ask the question, is this now a good control or not? And here you see the results. We tested 6 models, and 2 models were really quite good and could make the same results actually as the statistician, with an area under the curve of the best one from 0.83, which is in lab medicine a very good result for laboratory tests. So we are actually, with a 24-hour urine testing, really there that we can say, if we have a 24-hour urine of a CAH patient, we can give an idea out of the lab whether these patients are good controlled. And the same parameters came up again from machine learning and artificial intelligence, that the highest impact had these two metabolites, the PT and the 17-HP, which are precursors of the enzymatic block. To compare this with what is known in the literature, you can see here a paper out of another group in Europe who is also having the same machinery as us, with urine GCMS for diagnostic and research use. We are actually having the same components now on the plate that can discriminate for metabolic control if you have a 24-hour urine of a CAH patient. Stefan Woody had even a higher amount of numbers of patients at hand, and he also had urines of patients who were overtreated. So he was able to also say that overtreatment can also be seen from a urine through this metabotyping. So in conclusion, we dare to say that the 24-hour urine steroid profile can predict treatment outcome in children with congenital adrenal hyperplasia, even in the absence of clinical data. The machine learning, in addition, can spare time and can effectively interpret complex steroid profiles, taking 40 steroids and then reducing it to 2 and 5 to say whether under treatment or good treatment is in place in a patient, and support clinical decision making in the exception that the patient is compliant. And routine use of such comprehensive 24-hour urine steroid profiling may improve treatment monitoring because you don't have these snapshots, right? Because you are integrating 24 hours and you don't have this variability that we just heard about if you take a saliva or if you take a blood. The same you will have when you take a hair, right? Even for a longer period. Limitations are that we need additional validation studies, and the urine steroid profile is not widely available. That's really a big limitation, and the collection is of course often impractical, not really loved by most patients, especially not the girls, and therefore, yeah, these are real limitations. The next question, which is partially solved here by next paper by Stefan Woody's group, is the question, can we do the same from a spot urine? Would be much easier for routine. He did this study and published in children younger than 4 years, also in whom collection is much more difficult. So he took 60 children with CAH and can show with the same analysis, with cluster analysis, that he can classify in the 3 different groups of under treatment, well and over treated. And here you see very well the data of his area under the curve, which I think would have very good quality for also having in routine labs and highly discriminative. But of course, this also has to be validated by additional studies. Next question is then also, does a serum sample work? And I show you the same diagrams from Turku's paper published in 21, where they looked at daily profiles of patients treated with a pump treatment versus oral hydrocortisone treatment. And here you see it, the problem, the snapshots, right? I mean, even in pump-treated patients, you have certain variabilities, of course, much less than if you just give them the short-acting hydrocortisone. But the quality, when you look here, 17-OHP versus the 11-oxy steroids, yes, they are somehow promising, but I wouldn't bet too much on it, because look at the right-hand side, this area under the curve, the specificity is not to be implemented maybe right now for a routine lab, I have to say. We have to improve that if we will go back on serum. And we also have to make further studies, because now we are facing a FMODI. It will give different profiles, and the snapshots again will be different when you measure a saliva or a serum. So there is more work to be done to arrive there. And with that, I would like to thank everybody, and especially also the money providers for our studies. One was partially by SB and the other one SNF for my part of this collaborative study. And with that, yes, I'm ready for taking questions. Thank you very much for listening.
Thank you very much, Christa. Let us see if we have any questions here. Not for this talk right now, maybe it will come later, Christa, but I think we have one for the telomere talk. Although I think Ozair had to leave for clinical duties, but the question was if telomere length is shortened in patients overtreated with glucocorticoids.
Hello, Svetlana. I'm here, and I could
Yes,
ask
but
this question on behalf of Ozair.
yes.
Good afternoon, everyone, and I would like to take this opportunity to thank both Erika and Christa for the opportunity to collaborate in this project. Unfortunately, Ozair, who presented our data, had to leave because he's on call. The question, I believe, relates to whether the telomere length is shorter in patients with Cushing syndrome, and the answer is yes. It has been demonstrated that in patients with Cushing syndrome, telomere length was shorter compared to compared to the telomere length that the same patients had after remission. And also many studies have been performed that they demonstrated that chronic stress in general and hypercortisolism more specifically results in shortening of leukocyte telomere length. And I would like to take this opportunity also to say that it would be very interesting to see whether these findings are similar in case of use of the delayed and sustained release formulations of hydrocortisone, whether patients with the classic form of the disease who are treated now with the delayed and sustained release formulations of hydrocortisone also have similarly reduced leukocyte telomere length. We could repeat most of those studies in the future on different treatment regimens. Thank you very much.
Thank you, Leah, for clarifying. So we go on to the last speaker, which is Dr. Claudia Boettcher from Bern, who will talk about the effect of oral contraceptives in female adolescents with 21-hydroxylase deficiency, a prospective observational study.
Okay, I try to share that. Okay. Should work now, right?
Yeah, it works. Thank you.
Great. So, you are all familiar with the hypothalamic pituitary adrenal feedback control system that you see in this figure when everything is fine and perfectly working. But the situation is different in especially untreated persons with CAH, with congenital adrenal hyperplasia. Due to the inability to produce sufficient amounts of especially cortisol, we see a constant stimulation of the hypothalamic pituitary axis with increased ACTH and CAH, resulting in a chronic stimulation of the adrenal cortex and adrenal hyperplasia, ultimately leading to androgen excess. What are the treatment goals in CAH? We heard about that already from the former speakers. We aim for as physiological replacement of the lacking hormones as possible. We do so to prevent acute adrenal crisis and to reduce excessive androgen production. And in children, our goal is to promote normal growth and development. To achieve this, standard therapy involves sufficient glucocorticoid treatment, avoiding glucocorticoid excess, and mineralocorticoid replacement where appropriate. And oral contraceptives or OCs are only mentioned in passing as an additional therapeutic option in CAH. This scheme deals with the steroidogenesis in treated CAH persons. It's only an excerpt from the steroid biosynthesis in 21-hydroxylase deficiency, and you see the enzymatic block in pink, in purple. And the figure is not complete, but focuses on impaired cortisol production in the red frame and androgen production in the blue frame, including 11 oxygenating androgens. We heard about those. And we know especially the 11 oxygenated androgens like 11-ketotestosterone or 11-ketoandrostenedione are said to be essential contributors to the androgen excess in CAH. And please make a mental note of this figure as it will appear a second time in this talk. So what about oral contraceptives or ethinyl estradiol, EE2? Well, of course, oral contraceptives have contraceptive properties, but besides that, they decrease ovarian androgen production, that is known, but they also influence adrenal steroids. They achieve this by modulating cortisol balance, by stimulating the hepatic synthesis of corticosteroid binding globulin, and increasing free cortisol levels while extending the half-life of unbound cortisol and decreasing its clearance. OCs also upregulate sex hormone binding globulin and inhibit adrenal androgen production. And one possible mechanism is via LH, which is decreased under OC use. And we have forgotten that adult normal human adrenals contain LH receptors in the entire zona reticularis and the deeper layer of zona fasciculata, and the receptor-bearing cells are positive for steroidogenic enzymes. So decreased LH means decreased steroidogenesis. Last but not least, OCs seem to increase adrenal responsiveness to ACTH, but the data is not that strong, but I'll mention it. And altogether, OCs containing ethinyl estradiol seem to be the perfect medication, additional medication for CAH persons. You have seen this figure before. Now it shows the EE2 effects. So it lowers the ovarian androgens while increasing cortisol levels and corticosteroid binding globulin levels. It decreases adrenal androgens through low LH levels and possibly through another direct effect, and it may also decrease ACTH levels. With that in mind, we had a small preliminary retrospective study. We searched our records for patients with 21-hydroxylase deficiency who got contraceptives prescribed, not only oral ones, but all kinds of contraceptives. You see that some had patches and other stuff, and had data available before and under contraceptives. We identified 5 patients between the ages of 14 to 17, and they often had the treatment mixture of hydrocortisone and prednisolone, and they used, as I said, a variety of contraceptives, but most of them contained EE2. And what we found in these patients with 21-hydroxylase deficiency, that under OCs, the parameters that we rigidly measured in those persons with the AH decreased, namely 17-hydroxyprogesterone, androstenedione, free testosterone, and DHEA. And what was remarkable was that 2 out of 5 females could reduce the hydrocortisone dosage under contraceptive treatment. So that was the starting point where we said, let us design a prospective multicenter study to investigate the influence of oral contraceptives on the steroid metabolism in female adolescents and young women with classic 21-hydroxylase deficiency. And we decided that the OC chosen should contain EE2 and levonorgestrel. That's the inclusion criteria. Of course, females with classic 21-hydroxylase deficiency who already planned or were advised to take oral contraceptives, there had to be at least 11 years of age and with a TANA stage of at least B4, a bone age about 14 years, and no contraindication for oral contraceptives, and the medication should be only hydrocortisone and mineralocorticoids as needed. This figure illustrates the study's time frame, including visit 1 before oral contraceptives, 3 cycles post oral contraceptive initiation, and 6 cycles post initiation. All 3 visits included blood drawing in a fasting state and 24-hour urine sampling to obtain material for plasma and urinary steroid profiling, as well as other parameters such as SHBG, AMH, ACTH, renin, LH, FSH, lipid metabolisms, and glucose, insulin, and HbA1c. Then we did the steroid analysis. You heard that by Christa, by gas chromatography, mass spectrometry for the urine, and liquid chromatography, mass spectrometry for the plasma samples, and then used the Friedman test to compare urinary and plasma steroid metabolites and various blood parameters across 3 visits. And we choose a p-level of 0.005 as a significance level to compensate for multiple testing. Let's come to the results. We could altogether recruit 20 females with classic CAH with a median age of 18.7 years with a range from 11 to 26 years. The table shows the baseline characteristics with a median weight of around 60 kilos, height of 1.60 m, BMI around 22, and blood pressure in good control. Only 17 participants completed the study, 3 did not. 1 stopped the pill with a wish to become pregnant, and 1 had venous thrombosis related to COVID-19 infection, and 1 stopped the pill due to personal reasons. So let's go to the urinary steroid metabolite results. Let's start with the 11-oxypregnanediol. On the left-hand side, it's the urinary metabolite in 21-hydroxylase deficiency that can be used as a diagnostic marker in urine food disease. And what we nicely see is that from visit 1 to visit 3 to visit 2 to visit 3, the concentration per 24 hours decreases, and the same is true for the 11-beta hydroxyandrosterone. Same picture for the metabolites androsterone and ethylcolanolone, a decrease from visit 1 to 2 to visit 3. And next one for dihydroandrosterone, and the same for 11-oxo-ethylcolanolone. And what happens there? I'm sorry, that's DHEA and androsten trial, and you see the same pattern, mainly a decrease. What about the cortisol metabolites? If you sum them up, and I have brought them on the right-hand side, all the cortisol metabolites summed up, then you see in this violin plot a decrease overall in the sum of cortisol metabolites. So let's summarize for the urinary steroid metabolites. Under oral contraceptives, most androgen metabolites decrease, and the metabolites that accumulate before the enzymatic block decrease as well, and the sum of cortisol metabolites decreases. What about the plasma steroid metabolites? This is cortisol, and it increases from visit 1 to visit 2, and then decreases slightly again. Those are the figures for 7-dehydroxyprogesterone. It goes down nicely, and the same is true for androstenedione and for testosterone and DHEA. What about the 21-deoxycortisol? We heard about that in the second talk, and the 11-keto androstenedione and 11-keto testosterone. None of them reached our significance level, but nevertheless, you can see a decrease in all three over the 3 visits. But one of the problems with the Friedman test is that it does not deal all too well with parameters below detection limit, and that's what happened with the 11 oxygenated metabolites. What about the hydrocortisone treatment? This graph shows the hydrocortisone dosage per body surface area, and each line represents a different patient, showing individual reduction in dosage, and 8 persons received a reduction in their hydrocortisone doses over the study. So I can already conclude that we observe significant reductions in multiple androgen metabolites under combined oral contraceptives containing E2 in young adolescents and women with classic 21-hydroxylase deficiency. And the mechanisms behind are, I think, manifold. We noticed increase in plasma cortisol levels and a decrease in the sum of cortisol metabolites in urine. And this appears to be due to the estrogenic effect of the oral contraceptives. 8 women could reduce the hydrocortisone dosage, and altogether we can see a potential use of combined OCs as a complementary therapy in CAH, particularly for those with unsatisfactory steroid profiles, and of course in women only. And let me thank to all participating women and their centers in Armenia, Brazil, Germany, Sweden, and in Switzerland. And many thanks to the Steroid Lab and Steroid Research Group in Bern, and especially to those 4 women representing the women power in Bern. Thank you very much.
Thank you very much, Claudia. So let us see if we have any questions here. So we have one question to Christa. Great talk, Dr. Christa Flueck. Do you think this can be used in patients with Addison's disease?
Yeah, I have to say that if you take Addison disease is not one disease, so it really depends. Do you hear me, right?
Yes.
Addison is not Addison, right? And Addison is mostly defined by low cortisol production. Now it depends. If you have an adrenal which is completely off, then you just measure too little. And then I have to say you invest much too much in a steroid profile where actually only want to know whether the patient can produce aldosterone and cortisol. And therefore, this integrative urine steroid profiling in 24 hours, first of all, it's much better if you have a pattern, a change, which means a CAH, or a CAH, also POR, or all these steroid biosensitive disorders, which are giving a different pattern within the steroidogenesis of the adrenal. Whereas if you have something which destroys the whole steroid production of the adrenal, be it through autoimmune destruction or an ACTH receptor mutation, because then you have really only an answer: do you produce a little bit cortisol, and is there something left or not? And this, then you only have to order a cortisol and an ACTH to see whether it's a primary or secondary or tertiary disease. And then for the disease control also, maybe you only need that, and then it's much cheaper. And for that purpose, it's still, the immunoassays are still okay, and they are much cheaper, right, and faster to answer such a question. It depends a bit if you go into the question of Cushing's, right? But then again, you don't need the specific metabolites. You just order a free cortisol in the 24-hour urine to see whether the integrated production of cortisol is too much of over 24 hours.
Thank you. Do you have any other questions from the audience? No more questions. So I have a question to Claudia. So oral contraceptives, are you using it more and more now in your patients with CAH, the adolescents?
Yes, we do that.
Yeah.
Especially in those who we think could really benefit, and those teenagers are sometimes really difficult with the compliance or therapy adherence, and it makes easier for them. And I think if the mechanism is that the cortisol or the hydrocortisone stays longer in the system, they may really benefit. We'll do that.
If I may, would have a question to the team in Rotterdam.
Yes.
If you take such a hair and you cut it, let's say for 3 months, 3 centimeter, and you go centimeter by centimeter, can you discriminate whether the patient was in the 3 months ago bad and then 1 month ago better? Or does it, with this continuum, not allow such a discrimination, that if you take 3 centimeters, that maybe you see like in diabetics, or whether it's just like the A1C, that you have a mixture over the 3 months?
If I can may answer that question, Erika, we don't know. So that is
Okay.
exactly what we're going to study now. So we do know that for non-CAH patients suffering from Cushing's disease, like cyclical Cushing's disease, I think that's the most logical proxy. We really see that. So episodic hypercortisolism is really reflected in a spike of cortisol in the hair, ditto for cortisone in the hair. Whether or not androgens in hair, oxygenated androgens in hair, are a reflection of therapy efficacy, that is the exact study we are doing now. Going from the data which we have now, which I presented, so the preliminary data, we do see fluctuations of steroids in hair. So there is quite a high pretest probability that it will work. But maybe next year, if you have this webinar again, we can give you the definite answer.
Yeah. A follow-up question is, maybe, for sure you have seen this very nice study of the Finland group, where they take the first hair of the babies, right? And they were actually able to measure quite a lot of metabolites in this hair. But the hair changes quality, right? How long do we have such opportunities in babies? What do you think? Do you have any idea? And did you also go into the baby hair yet?
No,
in
not
CAH?
yet. So
Okay.
Maybe I can say something about that, because we also looked into that with respect to cortisol measurements in babies. And we saw indeed in the first year of life that it was very different, the measurements. And I think after 1 year, it changes. So it probably has to do with different type of hair, indeed.
Okay. Yes.
Yeah, so for cortisol and cortisone, we know that concentrations are much higher in very young subjects. So it has to do with the matrix effects of the hair. We know that now. So with ongoing technological process, we know that now, and it's also partly because the hair has a different growth speed. Just because we say that in adults 1 centimeter is 1 month, it's not by definition the same in very young children. So maybe you have to look into that in more detail prior to investigate. From the hair samples which we have done in the using the full steroid profile, we can already see that oxygenated androgens are measurable in hair from babies. Just by observation. We don't have any clinical data yet. We don't have any translational data. It's just pure, let's say, chemical observation that there is a possibility.
Would you like to say something, Evangelia?
No, thank you. I think all the presentations were great, and I think there is a lot more to do in CAH. So we could join forces, all of us, with other colleagues and do more research, particularly now that new medical compounds are available.
So thank you once again to all the speakers for excellent talks and very interesting subjects on the never-ending investigations on CAH, I believe, which is also my favorite disease. So thank you also to the audience that listened today, and we close this webinar now. Thank you very much. Bye-bye.
Very much. Thank you. Bye-bye. Thank you.
Bye-bye.